Thank you, Rosella. So it gives me honor, really, to be able to present our position with regards to the use of testosterone therapy for women. As you can see, this involved quite a large number of collaborators from a number of societies. And I think it does represent the state of the art as to where we think we are. Now, the objectives were to provide clear guidance as to who might benefit from testosterone therapy, to identify symptoms, signs, and conditions for which evidence does not support the prescribing of testosterone, to explore areas of uncertainty, to identify prescribing practices that have the potential to cause harm, and to discuss treatment options. So the IMS, led by Professor Susan Davis, invited societies to participate. They nominated their task force delegates. Susan Davis, in her department, performed a systematic review and meta-analysis, and the findings were shared with the delegates. There was a face-to-face meeting at EMAS in Berlin, and the consensus position statement was drafted. The statement was then circulated and reviewed by all the delegates, and then it was provided to participating societies and additional societies for endorsement. And the position statement was published on the 2nd of September earlier this year in 4 journals, as you can see there. So this is the first conclusion. The task force concluded that there were insufficient data to make any recommendations regarding the use of testosterone in premenopausal women for treatment of sexual function or any other outcome. There just weren't sufficient data to be able to make clear conclusions on that. However, testosterone therapy in doses that approximate physiological testosterone concentrations for premenopausal women exerts a beneficial effect on sexual function above the effects of placebo and comparator therapy. And these are the data that I want to show you from the meta-analysis. These are the satisfying sexual events by menopausal status, showing that for surgical menopausal women, this favored testosterone, and also for natural menopausal women. If we have a look at sexual desire, this also improves with testosterone therapy in postmenopausal women. Again, this is for surgical menopausal women, for natural menopausal women, and for the combined data for surgical and natural menopausal women. What's also important is with HSDD that sexual desire should be a distressing feature that then improves with treatment. And as we can see here, again, the data favored testosterone for surgical menopausal women, natural menopausal women, and the combination here overall. But we looked at other aspects as well. What about general well-being? The available data did not show an effect of testosterone therapy on general well-being, even though anecdotally we may see this in our patients. And perhaps there's a deficiency in the way we assess well-being in our patients from the quality of life questionnaires that we use. There was insufficient evidence to support the use of testosterone to enhance cognitive performance or to delay cognitive decline, and the available data did not show an effect of testosterone on depressed mood. Again, we know from treating our patients that we can see some improvements, but this was not shown in the meta-analysis. So these are the data here for cognitive performance, showing that there was no difference for immediate recall, delayed recall, or any other of these parameters here that were assessed. And these are the data for improvement in psychological well-being, and we can see that the data neither favored the comparator nor testosterone, although perhaps there was a signal towards favoring testosterone. What about bone mineral density? Because we know that endogenous testosterone does have an effect on bone mineral density, but supplementation at physiological levels in women did not show an effect of testosterone treatment on bone mineral density at the spine, total hip, or femoral neck at 12 months, and there was no significant effect of testosterone administered in physiologic doses on lean body mass, total body fat, or muscle strength. And we can see here the meta-analysis for bone density showing no overall effect there. So what about the adverse effects? Because this is one of the things that the regulators always talk to us about and have concerns about. Well, what we found was that systemic testosterone therapy for postmenopausal women in doses that approximate the physiologic concentrations is associated with mild increases only in acne and body and facial hair growth in some women, but not with alopecia, clitoromegaly, or voice change. So here we can see the data for acne, slightly favoring the comparator there, increased hair growth favoring the comparator, but not so for alopecia, clitoromegaly, or voice change. What about the adverse effect on cardiometabolic risk factors? Well, oral testosterone therapy is associated with adverse lipid profiles. There are negative effects on HDL cholesterol and LDL cholesterol levels, and therefore oral testosterone is not recommended. However, studies of non-oral testosterone therapy in doses approximating physiological concentrations had no significant adverse effects on lipid profiles over the short term. And these are the data for HDL in oral here on the left, which favors the comparator, but with the transdermal here on the right, it neither favored comparator nor testosterone, so the impact was neutral. Well, what about the breast? Because again, the regulators always talk about potential risks for breast and breast cancer. Well, the data that we had showed that testosterone therapy did not increase mammographic density, so a potential surrogate marker for breast cancer. The available data suggests that short-term transdermal testosterone therapy does not impact on breast cancer risk, but we must caution that the data in a randomized fashion were no longer than 2 years, so the data from RCTs are insufficient to assess the long-term breast cancer risk. So this is the meta-analysis of testosterone versus comparator for breast health, and here we have breast pain, neutral, breast tenderness, neutral, engorgement, the same, breast mass, the same, breast density, the same, and no adverse effect on breast cancer risk that we can see there. Unfortunately, the regulators still take the view that we need longer-term data, and this is what I think we should be working towards. What about serious adverse events, though? If we look at adverse events across the board from the RCTs that have been done, we can see that that favors neither the testosterone nor comparator. Again, neutral impact on serious adverse events. The problem that we have, and our previous speakers alluded to this, is that there is an unmet need for the provision and approval of testosterone treatment specific to women, formulated with the aim of producing approximately physiological testosterone concentrations. And this was expert opinion. And because of this, where an appropriate approved female testosterone preparation is not available, off-label prescribing of an approved male formulation is reasonable. And I think this is what a lot of us do in our practice. But with the caveat that we should provide hormone concentrations which are maintained within the physiologic female range. And use of any testosterone preparation that results in supraphysiologic concentrations of testosterone, including high-dose pellets and injections, is not recommended. So another area to which many practitioners turn because of the absence of regulated, approved products is compounded. So we felt that we had to make a position statement on this, and it was that compounded bioidentical testosterone therapy cannot be recommended for the routine treatment of hyperactive sexual disorder or dysfunction due to the lack of evidence for efficacy and safety, unless an authorized equivalent preparation, even if it's used off-label, is not available. So in the absence of an available approved product, If a compounded product is needed, the compounding pharma should be compliant with purity of active pharmaceutical ingredients and good manufacturing practice to meet industry standards for quality and safety. Once again, though, the dosing should be limited to achieving testosterone concentrations within the physiologic premenopausal range. What about monitoring and duration of use? Well, should a trial of testosterone therapy be given for HSDD, a baseline total testosterone concentration should be measured before commencement to make sure that the levels are not high already, and with a repeat level at 3 to 6 weeks, ideally, after treatment initiation, once again to make sure that the levels are remaining within the physiologic range. The patient should be monitored for their clinical response to treatment and assessed for signs of androgen excess with serum total testosterone level every 6 months to screen for overuse. It was felt that measuring free testosterone, although that may be more accurate, does not necessarily reflect a biologically active component of the total testosterone level. If no benefit is experienced by 6 months, however, it may take 3 to 6 months to see a benefit, then treatment should be ceased. So the final conclusion in this brief summary of the position statement is that the international panel concluded that the only evidence-based indication currently for testosterone therapy is for the treatment of HSDD, so distressing low sexual desire, with available data supporting a moderate therapeutic effect in postmenopausal women, but that there are insufficient data at present to support the use of testosterone for the treatment of any other symptom or clinical condition or for disease prevention. Well, ladies and gentlemen, with that, I would like to leave you with an invitation to join us in Melbourne for our next International Menopause Society World Congress at the end of April, beginning of May 2020. We hope to see every single one of you there, and thank you very much for listening.